When do you require it? When do you require it?
Fluid.
We will monitor the cardiac output.
Yeah. So if you want to do, when you want to do things like cardiac output monitoring, or you want to monitor the systemic vascular resistance (SVR), if you want to monitor the systemic vascular resistance, you require to have a CVP, because to actually find SVR number, the formula involves CVP. So in your monitor, if you don't put the CVP monitoring, you will not get SVR in your cardiac output. Are you understanding? So yesterday when I was asking you, tell me the SVR, you were unable to tell me because you haven't put the CVP monitor. The monitor will give you only those readings which I have told him, no? So CVP monitor has to be on. Okay, if the CVP monitor is on, then it will give you the systemic vascular resistance. Okay, volume resuscitation. Tell me more about volume resuscitation. So there are 3 ports in your central line. For example, their ports can be single, can be double, can be triple. Your multi-lumen central lines, double lumen central lines, and you can have single lumen central line. So if in a triple lumen central line that we regularly use, where will you use volume resuscitation? Which port will you use? So
Proximal.
Central port.
there are 3 ports in a central line. There is nothing called a central port.
I mean, the distal most, which is what?
So there are 3 ports. One is called as
proximal,
port,
middle,
other is called as middle, and third is called
distal.
as distal. Okay. For volume resuscitation, for volume resuscitation, I would use the
Proximal.
Distal.
so
Proximal.
for any central venous pressure monitoring, I will use the
Distal.
distal port. For central venous pressure monitoring, I will use the distal port. Right? The distal port is also used for
Sampling.
Blood
sampling.
Blood sampling.
It is used for blood sampling. It is used for blood sampling. Okay, you use the distal port for blood sampling. You use the middle port for
TPN.
TPN. Use the middle port for TPN. Right? And use the proximal port for
Inotropic support.
vasopressor support.
Medic.
And medications. That's what you use the proximal port. You must understand this.
These are lumens.
Lumens, yeah. So those lumens, internally what is happening is it is one housing and 3 lumens inside. But you should know what to use where. You can't use anything that you want anywhere. Now, why are they saying that hyperalimentation you require a central line? Why are they saying this? Why are they saying that TPN you require central line? When you say hyperalimentation, what do you mean? TPN, but any
Hyper.
clue, any idea?
Hyperosmolar because
Osmolality is more.
So any solution that is more than
Hyper.
900 milliosmoles, any solution that is more than 900 milliosmoles is known to cause irritation of the vessel. Is known to cause irritation of the vessel, and that is why hyperalimentation. Hyperalimentation में क्या होता है? Total parental nutrition का milliosmoles if you read the bag is 1200 and 1500 milliosmoles per liter. So you can't use total parental nutrition. That is why if you want to use it through a peripheral IV line, I would use peripheral parental nutrition. When I say peripheral parental nutrition, there the milliosmolarities are much lower, less than 900. Clear? So I would not want to use hyperalimentation through a peripheral line because higher the osmolarity, higher the irritation, higher the problems. Clear? That's why TPN has to be given through a central line. Peripheral parental nutrition also is hyperalimentation, but peripheral, where the osmolarity is on the lower side, I will use it in the peripheral line. Clear? Similarly for the concentrated solutions, like mannitol, KCl. Mannitol, KCl. Clear? Hypotonic saline, 513 milligrams per liter. So it's not too much of a problem. Around 900,000. People only once, you're not giving continuous. You don't need a central line for that. Okay? Pacemaker, what is this transvenous pacemaker? It's TPI. So for that you require a sheath. The sheath is going into the central vein. Sheath लगता है उसके लिए. Okay? Sheath goes into the central vein. And that is why your placement of a transvenous pacemaker requires you to put a central line, which is basically a port that goes over here. Right? A sheath you require over here. Cardiac catheters in pulmonary angiography and hemodialysis. Clear? Yeah? Let's go ahead. And what is the commonest cause for having a central line? Volume resuscitation never requires a central line.
Lack of peripheral.
Volume resuscitation is always peripheral line because the speed with which the volume can go is always faster with a smaller line. as compared to a larger line. So volume resuscitation always it is peripheral line.
Peripheral line.
Okay, but what is the commonest reason to put a central line in the hospital?
Lack of peripheral
Lack of peripheral access. That is the commonest reason. A lack of peripheral access only you see this very often, right? Peripheral access नहीं मिल रहा तब हम line डाल रहे हैं. That's very often, right? Huh? Let's go ahead.
So you smaller you mean in length?
Lengthwise. The
Diameter-
smaller the line,
diameter.
the faster the speed. Okay.
radius.
Relative contraindication of CVP line. It's a bleeding disorder or the anticoagulation of thrombolytic therapy compared to patient distorted local anatomy. In case of cellulitis, burns, severe dermatitis at the site, and in case of vasculitis.
Very important. So when I say bleeding disorders, that is the reason that before putting in a central line, the prerequisites
PTA.
would actually involve you to check the bleeding disorders. Alright, and then make a judged clinical estimate as to whether I will be using this, whether I will be putting the central line or not. It has to be very clear. If the PTT is high, what is the reason for it? For example, you have an INR that is 4, but this patient has a liver cell failure. INR is going to be 4. उसमें problem नहीं है मेरे. You understand? But if you are a normal person and INR is 4, I can do this. Because the benefits are much lesser than the risks of putting something like this. Are you understanding? It is not an artery that you are putting here that you can press like this, or vein you are putting here you can press like this. It is here. Once it is punctured, very difficult to stop that bleeding. Okay? Yeah, let's go ahead.
For the complication of CVP line, vascular complication includes air and bolus.
How does it occur?
तो अगर properly उसमें air वो रहेगा flushing.
How do you prevent this? How do you prevent this? So A is that you don't insert when you're inserting the central line, tell the patient not to breathe heavily. Number 1. Tell the patient not to breathe heavily. If the patient is going to breathe heavily, is very tired, that's why when you say combative patient, don't do it. The combative ऐसे सब कर रहा है, that time he breathes internally, बाहर से हवा अंदर घुस जाएगा. Second, how to prevent air embolism? Whenever you are starting to put your central line, flush and prime with fluid. Whenever you are putting a central line, don't just keep the central line there. Flush and prime it and keep it ready. Let fluid be in that. That lock is for that. You see the lock? You have a lock. You see na? On a central line there are 3 locks. So you put water, close the lock and keep it. Put water, close the lock and keep it. So two ports are going to be closed when you are putting a central line. When you are putting a central line, 2 ports, barring the distal port, are going to be closed. You understand? When you put a central line, that will avoid your understanding. So combative patient should be very nicely calm. Second thing, you are ensuring that the 2 ports, extra ports that you have are actually primed and locked. Primed and locked, वहाँ से हवा जाएगा नहीं. The reason for that is that only. Also, when you are putting the line, if you don't lock it, when you put the line, the whole blood will come out. So that's why you want to lock it. Okay, right? Next.
The infectious complication.
नहीं, arterial puncture. How do you avoid this? How do you avoid this?
उसको बराबर से USG repeat करना है.
So the arterial puncture can be avoided by actually doing ultrasound guidance. The only way you can do it is by doing an ultrasound guidance to find out what is the vein and what is the artery. How do you find that out?
Compressibility.
A, compressibility. 2,
Pulsation.
pulsatility. Compressibility and pulsatility. This is very clear. An artery generally is bigger than the artery generally smaller than the vein. Okay, now that's how it is. Anatomy, how it lies in the body. Arteriovenous fistula. If you actually plan through and through, if you do, you can arteriovenous fistula. Hematoma and blood clot. Yeah? ठीक है.
Infectious complication of CVP line includes sepsis, cellulitis, osteomyelitis, and septic arthritis.
Yes.
And the miscellaneous complication.
Miscellaneous complication. How does dysrhythmia happen? How does it happen?
Patient can go into arrest.
How dysrhythmia? क्यों होता है dysrhythmia?
Diagnose.
No. Why does dysrhythmia?
guide wire goes.
Yeah, so whenever you're putting in a catheter, so there are various reasons why patient goes into dysrhythmia. One of the reasons that they go into dysrhythmia is the fact that as you're inserting the guide wire may go and abut onto the wall, which might cause a ventricular premature complex, and in an event that you're putting the central line in patients who probably have electrolyte imbalances, they might go into a ventricular rhythm and they might arrest. Okay, that is one possibility. Second thing is when you have patients with gross left bundle branch block. There again, when you stimulate the wall, there is a chance that heart block will occur. Okay, so these are few places where you can have problems. Dysrhythmia there. Clear? Dysrhythmia. Then catheter knotting of my position, when does this occur? is normally for a swan gans, not for a central line. This is for a swan gans. Malposition can occur when anytime if you have resistance while passing the line. So the moment you have resistance while passing the line, it is imperative to stop doing the process. Come out and reinsert. Do not try to force the line if there is resistance. It is bound to go to another place. Okay, we are having a single path of blood. Do not insert when there is a nerve injury. Any of these line catheters have got vein, artery, nerve. So nerve injury can occur in those cases. Pneumothorax, hemothorax, hydrothorax, hemomediastinum, bowel or bladder perforation. That is why I am putting it over here. Okay, next.
Types of central venous catheter include non-tunneled, peripheral inserted central catheter peak, and implantable port.
So what are these things? What is a non-tunneled central catheter? What do you call as what is a non-tunneled central catheter? A non-tunneled central catheter is the usual catheter we are using. अभी हम जो use कर रहे हैं, that is called as non-tunneled central catheter. What we are using now, a triple lumen, multi-lumen central line, that is a non-tunneled central catheter. You understand? All of these are non-tunneled central catheters. Your dialysis lines, your central lines, they are all non-tunneled central catheters. What is a tunneled central catheters? Perm cat. A perm cat is a tunnel. It goes from here, goes inside. Okay, perm cat. It causes less infection because it's a whole area that is outside. Then it goes inside the vascular system. So it's outside. The whole area is outside the skin and soft tissue, and then it is going to the vascular system. So channel infection. What is peripherally inserted central catheters? What is this? So a peripherally inserted central catheter is you are inserting from the periphery and going into the central circulation. This is peripherally inserted central. Why don't we use them regularly? Thrombosis, because our patients that are putting them are all inflamed patients. There are patients who have got an acute host response. There are all patients who have released prostaglandins, cytokines, interleukins. These patients have endotheliitis. There is a chance of thrombosis. So when you have a longer catheter in the vessel, the entire endothelium is exposed to the vessel. There is a high chance of having a clot. That is why we are not using peripherally inserted central catheters. Last one. What is this? What is this? So you have seen a chemo port. Chemo port is a implantable port. You see the port inside. The port is from inside and goes into the heart. From inside only goes to the heart. That's a implantable port. Okay? Clear? Yeah. Next.
Non-tunneled port. It is used for the short-term therapy. Inserted percutaneously. The site of insertion includes subclavian vein, interjugular vein, femoral vein. It has 1 to 4 lumen of ports. It is usually from 6 to 8 inches in length.
So when you see the length, you actually how do you check the length? Length is from the tip of the tube to the two lines that are there on the central line. Okay, that is the length usually. Okay, not to the Y, not till that opening. The multi-lumen port is there, not there. It is up to the two lines that are there. You must know that, because if you go to put a 15 centimeter line, you should know that I am already in. I am much more in. I don't need to put the whole thing inside, right? Yeah.
Tunnel catheter are passed under the skin from the insertion site to a separate exit site where the catheter and its attachment emerge from underneath the skin. It is used for the long-term therapy, inserted surgically. A small diaphragm cuff sits in the circulatory tunnel. No dressing is required after the cuff heals unless the patient is immunocompromised. Initially sutured but it can be removed in 7 to 10 days. External portion of the cap can be repaired. Commonly used tunnel catheter includes Hickman catheter and Crosson catheter.
So this is the perm cap, okay? The perm cap inside has got a tunnel and inside there is a cuff. So usually there is fibrosis that develop around that. There is complete fibrosis develop around that. So you cannot just pull it out like a center line. It needs to be opened up with an artery forceps and then it needs to be taken out. Okay? Yeah. And no dressing is required unless the patient is immunocompromised.
Peripheral inserted catheter. It's a central venous catheter inserted into a vein in the arm rather than a vein in the neck or the chest with a tip position in the superior vena cava. It is used for the intermediate to lower therapy, maybe single or double lumen, inserted percutaneously into a basilic vein or cephalic vein threaded into superior vena cava.
Good.
The technique which uses the legal technique in which use introducing needle to locate the vein. Wire is then threaded through the needle. Needle is removed. The skin and vessels are dilated with the help of the dilator. The catheter is placed over the wire. Then wire is removed and the catheter is secured in place. These are the steps. Basic principle. Decide if the line is really necessary. Know your anatomy. Be familiar with your equipment. Obtain optimal patient positioning and cooperation. Take your time. Use external technique. Always have a hand on your wire. Ask for help. Always aspirate at your advance. As you withdraw the needle slowly. Always withdraw the needle to the level of the skin before redirecting the angle. Obtain a chest X-ray post and placement and CVP.
It's very important to know all these steps, okay? Do not rush to put in a central line. There is no hurry, first of all. Be very slow when you want to put a central line. Okay, there is no problem. Go slow. Because the problems, if it comes, it becomes too much. Number one. Number two is there are few things that you remember when you're putting in a central line. That full aseptic precautions have to be followed, which includes gown, glove, cap, mask for you, the operator, and the whole body has to be draped. The whole body has to be draped. The third important thing that you must remember is that when you're cleaning, clean inwards to outwards and ensure that there is enough time for it to dry. Do not wipe it. If you are wiping it, you are losing everything. So you are going to go inwards to outwards and then you are going to ensure that it dries off. It's very important that it dries off. You cannot wipe it off. For example, if you are going to use betadine, it needs 3 minutes time. You wait for 3 minutes, and 3 minutes is a very long time when you are standing without doing anything. Okay, chlorhexidine requires anywhere between 30 seconds, 20 to 30 seconds for it to dry. You have to wait. Even that 20 to 30 seconds is too much. You have to wait for it, right? Another thing is when you are putting the line inside. When you are putting the line inside and you have put in the guide wire. Say for some reason you want to manipulate the guide wire and the guide wire doesn't come out. What do you do? It's not coming out. What do you do?
Whole assembly.
You remove the whole thing out. You don't try to remove the guide wire. Okay, what is the guide wire? The guide wire is actually a small wire on which a spring is attached. There is a small spring that is attached. If you try to remove the guide wire, there can be fracture of the guide wire because the spring will break out. The spring will break out. That is why you don't want to pull out the guide wire if there is resistance. If there is resistance, what you need to do? The whole set has to come out together as one unit. Never try to remove the guide wire on its own. It can be alarmingly dangerous. Right? Yeah. Next. Yeah.
This includes the guide wire, the development poles,
Yeah.
The subclavian approach. The positioning right side is preferred. Supine position, head should be neutral position, and arm should be abducted. Cantilever degree 10 to 15 degree. Shoulder in neutral with mild retraction. The right side is preferred. Needle placement at the junction of the middle and the medial third of the clavicle. At the small tubercle in the medial dead to pectoral groove. Needle should be parallel to the skin. Aim towards the supraclavicular notch and just under the clavicle.
Yeah, next. Yeah, let's go ahead. So what you see over here is middle and the suprasternal notch. So it's always better to actually direct the needle such that this is in straight line with the suprasternal notch. So if you keep your hand on the suprasternal notch and you actually go from the middle lateral 2/3 and middle 1/3 of the clavicle, you actually point it towards your needle. Point it towards this suprasternal notch and you will probably get it under the rib. You walk it over the rib. So you first hit the rib, then go under the rib. Okay? Yeah.
Internal shoulder approach. Positioning right side preferred. Frontal position should be there. Head turns slightly away from the site of veniculture. The needle placement. Central approach. Locate the triangle formed by clavicle and the sternal and the clavicular head of the sternal needle.
So now we are not really using this because we are using this central approach, but we are using an ultrasound. Okay, but importantly, do not go on the ultrasound perpendicular. Go on the ultrasound in an angle of 15 to 20 degrees. Otherwise, you will cause increased incidence of thrombosis. Right? Huh? So interjugular vein palpation. Femoral is go to femoral.
Positioning, supine position should be there. Needle placement medial to the femoral artery. And needle head at 45 degree angle. Skin insertion should be 2 cm below the.
So do not go above the inguinal ligament because you will never others figure out retroperitoneal hemorrhage. So don't do that. Okay, it has to be under the inguinal ligament. Yeah, go ahead.
Aim towards the umbilicus.
Yeah. Yes.
Complication of central venous catheterization. It includes pneumothorax.
We went through that.
pneumothorax, arterial punctuation and hematoma, brachial plexus destruction, heart arrhythmia, and symptom of pleural puncture during central and in conscious patient are coughing, pain at the site of the punctuation, drop in BP and dyspnea.
Okay.
These are the advantages or disadvantages of the different sites of CVC. In case of interjugular vein, the advantage in bleeding can be recognized and controlled. Malpositioning is rare, less risk of pneumothorax. But there is a risk of cardiac artery puncturation. Carotid artery puncturation. In case of femoral CVC, femoral catheterization, it is easy to find, low risk of pneumothorax. It is a preferred site in case of emergency in CPR. There is a fever bad complication which includes higher risk of infection and risk of DVT. And it is also not good for the ambulatory patient. In case of subclavian catheterization, it is most comfortable for the conscious patient, but the highest risk of pneumothorax and should not be done on the intubated patient. It should not be done in case of the patient is less than 2 years and vein is non-compressible. Post-catheter placement. Aspirate the blood from each port, flush with a line or sterile water, secure catheter with suture, cover with a sterile dressing, tegaderm, obtain chest X-ray for IG and subclavian lines. Write a proper procedure notes.
Okay. So the maintenance of the line, how often do you change the dressings? So you are there in this dressing station, maintenance here, right? So what is how long? How do you change the dressings? What kind of dressing do you use here? Nahi hai. Okay. So this is a procedure note. Indication of the procedure has to be there. Comment on the consent if there is. Describe what you did and how does the patient tolerate any complications. Fair enough. All right. We already spoke about this. Okay. Okay. Ultrasound guided catheter, IJV, carotid artery. Clear on this?
Yes.
Okay. So, which kind of dressing would you use now since nurses are also there? Huh? Which kind of dressings do you use for a central line? Tegaderm. So, a tegaderm is generally used so that you can see it's hygroscopic, it's easy to look at it. So, you do not change the tegaderm for how many days, or do you change it every day? Sachin?
Not every day, sir.
Then every second day, third day?
Third day.
No, it's every 7th day. Okay, the tegaderm is changed every 7th day. You must know this. Okay, you don't change the dressings every 3rd or 4th day. You change it every 7th day unless the dressing has come out. Soil तो होता ही है, but come out. If the dressing has come out, for example, it's put on hair and has come out, then probably you would want to put a new tegaderm dressing. So every time the tegaderm dressing, you have to notice what is written on it. उस पे date लिखा हुआ रहता है. You have to see the date. 7 days later, it needs to be changed, right? What about if there is bleeding? What dressing would you use? Dynaplast. So dynaplast requires to be removed when? It's every 2nd day. Okay. So today, tomorrow, classically, when the patient is getting turned or they're getting bed making is done on 2nd or 3rd day, that is when the dynaplast is removed, or if it is soiled or out again. So dynaplast cannot be removed every day, not every 7 days. It is every 2nd day. Okay, after 48 hours, you are supposed to get off the dynaplast dressing unless it is soaked and if it is damp and if it is taken out. That's about dynaplast. What about the IV lines? So, what if you have giving blood? So, blood you giving from which port we discussed? Distal port, right? If you are going to give blood from the distal port, you are going to give it through a blood set. So, the blood sets needs to be changed right after use. Okay, if you are having 3 bloods in succession, give 3 bloods and discard. But if you are having only 1 blood for the day, 1 blood you have given and then you discard. It's not supposed to be repeated. Okay, the blood set is done, it has to be out of that place into the bin. Okay, blood set. What about IV sets?
96 hours.
96 hours. Ideally, IV set should be given for once in 96 hours. What about TPN? Single 24 hours. Okay, so because your TPN is for 24 hours, that's why 24 hours. Okay, after 24 hours you want to change your TPN. Okay, we are not very clear whether we can use the same, if we are using TPN for more than 36 hours, we are not clear. But 24 hours is what we want to keep, just like how we do for blood. Blood set में क्या होता है? You still, in blood set what happens? You keep the blood, if blood is over, you throw it. But if you have 3-4 bloods, we use it after this. TPN में what happens is, if your TPN is on, okay, you can still wait for 24 hours if it stops. And then you can discard the set. Of course, we don't want to do it like that. Clear? Clear on IV sets? hub, the scrub the hub is very important. So whenever you are going to actually touch the central line, ideally what you're supposed to do is wear gloves. You cannot touch the central line without wearing gloves. It is not right to touch the central line without wearing gloves. Hand wash followed by gloving, and then if you want to access the port, you're actually supposed to open and scrub the hub. It's very important to scrub the hub with alcohol or with a gauze piece and then access the ports. Right? All ports that are not used, we don't just lock it and keep. All the ports that are not used, we either put a very small IV fluid that is going on at say 5 or 6 ml per hour, okay, or maybe 2 ml per hour, or you flush the line and lock the port. It has to be flushed and locked. You cannot leave the port like that only. It cannot be left like with blood in it, or it cannot be left because blood, it will block, because you must understand a multi-lumen set will have 3 lumens where you can't see. Inside the catheter housing, there are 3 lumens, and by any chance if there is blood getting into any of those lumens, the catheter will get blocked. Are you understanding? And that is the reason that you are supposed to flush it. That is why many countries in the world don't allow to flush and block. They actually tell to keep the vein open by giving 2 or 3 ml per hour of fluid. That is why many countries in the world, they say don't stop the. That's why when there is Lasix on board, I say don't convert. Let it be 0.1. Let it be 0.2. What it does, it actually keeps the line open. Are you understanding? I don't convert to that because I know that line will get blocked otherwise. Are you understanding? Clear? Huh? ठीक है, सारा dashboard.